what is this ISPC Online Pain Gurukul is. So this ISPC Online Pain Gurukul, it is an educational initiative which has been taken by Indian Society of Pain Clinicians for all the budding pain physicians or all the who are already undergoing the pain fellowship in the form of PTCC, PDF, or fellowship programs, or the people who are in anesthesiology, residents people, or who are thinking of taking the pain medicine as a career option, to give them a platform to have an idea what the pain physicians actually do and what all are the things in their bucket, so that they can decide in their future goals कि pain can be a future careeristic option. And so we had, in the first meeting, it was taken by Dr. Anurag. It was about the basics of the pain medicine. In the second meeting, it was about the radio frequency thermocoagulation. Third was by Professor Virendra K. Mohan about the trigeminal neuralgia. And the fourth is today's meeting. So I will invite Professor Virendra K. Mohan. He's a professor in Department of Anesthesiology, Critical Care and the Pain Medicine in AIIMS, New Delhi. I would like to invite Professor V.K. Mohan to invite Dr. Anurag Agarwal. Sir, yes, sir.
Today we will be having a first of the webinar. It's a series of webinar. Will be incorporating endoscopic dissecting, and our first webinar is on demystifying percutaneous spine endoscopy for pain physician. And it's my pleasure to invite Dr. Anurag Agarwal for this webinar. And Dr. Anurag, as you already know, is a professor of anesthesiology and pain medicine at Ram Manohar Lohia Institute of Medical Sciences, Lucknow. And he is one of the first pain physicians who started doing this particular endoscopy procedure in India. Dr. Anurag, please.
Thank you, sir. Thank you for your kind introduction. And I first wish my good wishes to all the listeners and viewers on our webinar. Today is the first, as Professor Mohan sir has already spoken, that today is the first of the limited series on percutaneous spine endoscopy. And we are today's lecture is not a very technical lecture. We will have them later on, one by one, by the eminent speakers. Today's lecture is only on the my view about how to go about it, why to go about it, and so on and so forth. So to start with, this is just a disclaimer that I have used few slides from the internet, as well as I may take some names of organizations and brands just for the sake of better understanding. We have taken the proper consent from the patients, which we will show here. So this is me. I am working as a pain physician and associate professor at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. And I have done my PDCC from Banaras Hindu University under Professor Virendra Rastogi, who is also our founder president. And he is the founder secretary of Indian Society for the Study of Pain also. So this is something which our newbies, new generation of pain physicians should know. So now the question arises that we are going to talk about percutaneous spine endoscopy, but how the things started. So just a glimpse into the history. That because of the founders like Professor J. Bonica, Professor P. Prithviraj, Professor Virendra Rastogi sir, Professor Anil Agarwal, Professor G.P. Dureja, and so many across the world, they taught us pain physicians to focus on the chronic pain syndromes and pain generators. And it happened somewhere in 60s and 70s of last century. And when it was really unheard of that why should we take care of pain? Pain is the part of life. But they thought, no, it's wrong. We must focus. There has to be someone, some class of doctors who will focus on the chronic pain syndromes. And they also at the same time discovered minimally invasive pain and spine interventions for low back pain and radiculopathy. One of the most common reason of doctors visit across the world. Actually, low back pain is currently the second most common reason of doctors visit worldwide. So they discovered MIPSs for the low back pain and radiculopathy, like the transforaminal epidural steroid injections, or now we call it neuroplasty. So they taught us how to do it. Then they take us ahead to the percutaneous disc decompression methods, like the nucleotomy. Common name is nucleotomy, also known as automated percutaneous lumbar discectomy. Then came nucleoplasty, then came decompressor and ozone disc injection, which have been very popular both in India as well as in Italy especially, and Europe. And even now, they have been embraced by many US people also. So, one major thing is that we must all understand that all these bread and butter MIPSs for the pain physicians practice are with help of C-arm fluoroscopy. C-arm fluoroscopy, if I take it as a matter of fact, that it is like the stick of the blind. Most of the pain physicians can't do, or must not do, rather can't do any intervention, especially across the spine, near the spine, without the C-arm fluoroscope. It is must for the precision, it is must for the safety of you as well as your patient. So these elders, these inventors, discoverers, like Dr. Bonica, Dr. Rastogi and all, they taught us and they made us proficient in the use of C-arm fluoroscopy more than any other specialty. This I can tell you with a bit of confidence that so many other specialties are also doing C-arm fluoroscopy for their day-to-day work, like orthopedics, like neurosurgery, like even interventional radiologists. But perhaps we pain physicians use it more in the complex way. We twist, turn, oblique, less oblique, more oblique, lateral, AP. So they made us proficient with use of C-arm fluoroscopy. And why I am telling all this story before I started talking about endoscopy, perhaps you will understand in a moment. So there is a word about the evolution of percutaneous disc intervention. As I told earlier, it started actually with the chemical discectomy with the intradiscal chymopepin. Quite a popular method in the 60s and 70s era, but then somehow went out of favor. Used to be very good method for the contained disc herniations, and then came the nucleotomy or APLD, then came nucleoplasty, which is actually a coablation technique with the help of radio frequency. Then came the decompressor, which is a mechanical decompression of and removal of disc material, that is nucleus pulposus. There was one major, one very common point with all these interdiscal percutaneous disc removal techniques. Then in all of these techniques, the probe or the needle they used to be in the center of disc. They all were done with the help of C-arm fluoroscope, and they used to place the probe in the center of disc, both in AP as well as in lateral picture of C-arm fluoroscope. Again, this sentence will make some sense after a few more slides. And all of these percutaneous disc interventions, like APLD, nucleoplasty, decompressor, they were found to be quite useful and effective for the young, soft and contained disc. So there are two important, actually all three important factors are there. That the young means with the acute or subacute onset. Then soft means that this should not have been calcified, and contained means that there should not be any extrusion or sequestration. There it becomes less effective, I would say, not a failure. So just a slide to take you back how we used to do the these interventions, be it ozone, be it chymopepin, be it APLD, be it nucleoplasty, that we make a Scotty dog picture. Every pain physician worth his salt knows this picture. And we square, we bring the SAP in the halfway around the end plate, lower end plate, and then we mark a point and go in a gun barrel view. As you can see with the red dot here, this is the entry point for the all these percutaneous disc interventions. Here you can see that, as I told you earlier, in all these techniques, almost we used to place needle in the center of disc, both in AP as well as in lateral. This is again a representation of this device is decompressor by Stryker, mechanical device, high speed rotation and removal of this. So there was a limitation of these interventions, that all of them are blind. Like you can see only on the CM fluoroscope. You cannot see it directly what you are removing, what you are cutting, what you are touching. And they are, as I told you earlier, they are good. They were good for the non-contained herniations. So they were good only for the contained herniation. So the question arose that what to do with the non-contained herniation. And then the answer came from Dr. Parvez Kambin, who described an entry for the epidural space where the disc is actually protruding or extruding, which is a God-given entry. That is known as transformal route, or better known as Kambin's triangle. So this route, when it came early 90s or late 80s, then Professor Anthony Young in America and Professor Satishan Gora in India and Dr. Hoagland, Thomas Hoagland at Germany, they explored further and popularized this route to gain the entry into the anterior epidural space and the disc to remove the disc material by introducing the transforaminal endoscopic discectomy. So this is just a picture of the Kambin's triangle to make you understand the philosophy of Dr. Parvez Kambin. That you can see that this is the lateral picture of spine, and you can see this is the exiting route. This is the upper vertebral body. This is the lower vertebral body, and in between, and this is the traversing route or dural sac. In between this area is the Kambin's triangle. This area here you can see the disc, and this is our target where we want to reach. So this Kambin's triangle, one obtuse border is made by the exiting nerve, another limb is made by the traversing route, and then another part is made by the upper end plate of lower vertebra. And in between this triangle, these boundaries, we need to place our equipment to remove the herniated material without touching or without harming either any nerve root, or without cutting, or without removing any muscle or bone. So this is the beauty of this route for which we use for the transformer. So why it was required to go for the percutaneous disc techniques? Because like across the world, you can see this slide that we used to have the big telephones. We reached to the mobile phones, and then we are practically living in a virtual world. Same way it happened. We used retractors, used big surgeries, then microscopic surgery. Now they are percutaneous methods. So world is moving towards the minimal, and the dictum now is minimal is maximal in all the fields, including the pain medicine. So why we pain physicians should embrace this technique? Because that we are already well versed in doing minimally invasive and percutaneous disc interventions like discography, like ozone, like APLD, like nucleoplasty. So it seems to a natural progression for us pain physicians to climb from intradiscal ozone and other minimally invasive pain and spine interventions to percutaneous spine endoscopic interventions. So this is nothing like a rocket science. This is the reason this is one slide I have made for one of my actual publications we have sent it. So this is the evolution of percutaneous minimally invasive treatment for the radiculopathy. So you can see that first we start usually with the 4 to 6 weeks of conservative care. If it works well, if it doesn't work, we progress to the transforaminal epidural steroid injection or neuroplasty. If the relief is adequate, well, send the patient for rehab. If it is not adequate relief, then there are two methods. You can either go for the, if the disc is contained on MRI, you can go for the chemical decompression like chymopepin or APLD or nucleotomy or nucleoplasty or something like that. If it is non-contained, then you better go for a percutaneous endoscopic technique to remove the herniated material and provide long-lasting and treatment of the PIVD. So it can be. So what are the benefits of advantages of percutaneous spine endoscopy? That this is a definitive treatment. This is perhaps the only treatment in whole pain medicine which can be objectively proven that this is what we have done. This was the earlier MRI, this is the later on MRI, this is the disc material we have removed. So this is definitive treatment. This is minimally invasive and percutaneous. Because of this nature of minimally invasive and percutaneous, there is, of course, minimal morbidity to the patient. Most of these interventions, endoscopy, are done under local anesthesia, at least in India and many other parts of the world. So you can avoid the cost as well as the complications associated with general anesthesia. Because of the minimally invasive nature, there is almost immediate mobilization of the patient. Again, patient can come back to their life and social life as well as professional life very soon. And efficacy is, as per the literature, coming out very fast. Efficacy is almost same to the any gold standard, previously understood gold standard treatment. So question arises, who all are practicing spine endoscopy? So let me tell you very humbly that it's a new field for everyone. You don't think that who is proficient in the open spine surgery has to be proficient in the endoscopy also. This is an altogether different ball game. Everybody has to tame themselves with the right approaches, and there are different requirements for both of the practices. So currently it is being practiced by the pain physician, by the neurosurgeon, by the orthosurgeon, intervention neurologist, intervention radiologist, and so on, and PMR guys, and all of them are trying to do their best. And it is good that this technique is really required for the masses and the load of patients we have in our society as well as worldwide. So there is no competition, but everybody, whosoever is doing it, should do it correctly and efficiently and confidently, and it will help in the larger run to the whole society, that more and more competent person are there. So as a pain physician, I would like to talk about the shortcomings as well as the strengths of us pain physicians in this field, because this lecture and this series is basically for the pain physicians and to understand and help out what are the problems. So where do we have an edge? That we are trained to find out the pain genetic. Second thing that I have already mentioned, we are very much proficient with the C-arm fluoroscope and its different use in the different direction, different orientations. And that is the reason we are quite efficient with the fluoroanatomy, which is certainly different from the clinical anatomy. Like the normal anatomy, then comes the clinical anatomy, then comes the fluoroanatomy. So we are good with that. We are using posterolateral Cambine's triangle since ages. Perhaps before it was formally described by Dr. Parvez Kambin. We were using it for the transforaminal epidural steroid injections. So there and here in the TFESI safe triangle approach, there we go above the exiting route, and for the interdiscal route we go below the exiting route. That is the only difference. So we are using it Cambine's triangle. We are well versed. We are also well versed with the needling. needle placement in the foramen and around the nerve for the transfemoral lipid injections, for intradiscal procedure, for ozone injections and all that. So we are good with the needles also. Everybody has got their strength, and we are very good. Being most of us are from anesthesia background, so we are very much used to work with local anesthesia. Where do we lack? This is very important. It is important to know the weaknesses also, so that we can work on them. We are not used to live anatomy, which is seen on the endoscopy. So first time when you go inside the foramen, inside the disc with your endoscope, you get overwhelmed. I was overwhelmed. What is there? क्या दिख रहा है? मतलब I cannot discern between the different anatomical structure. What is what? Where is nucleus? Where is annulus? Where is nerve? Where is bone? So we need to learn that. We are also not comfortable with blood in the field. There is a small drop of blood. With the strong magnification of endoscope, that blood looks like a flood of blood coming towards you, and you get scared initially. So we need to overcome that also. We need to understand. And then very important thing that in our understanding that complications are part of it. You wish or you may not wish, you like, you may not like, but the complications unfortunately do happen, and they happen with everybody, each and everybody in each and every field. And as they say in the English literature, that if you work well enough, you will see each and every complication given in the book, or perhaps more. So this we need to understand. When there is a game, there is a complication also, and you need to have a team to play their specific roles. So this goes with everybody, that we need friends, we need colleagues, and this is our moral responsibility. There is nothing like putting some burden on anybody, or get them called here and stand with you. Not like that. Just have a relationship, so that as you deal with their complication, they will deal with your complication. This is a professional world. So that goes like that only. This is how world moves. So what are the requirements for the percutaneous spine endoscopy to start with? So I just want to stress upon again that good knowledge of all pain medicine and pain generators specifically in the spine. You do not want to put an endoscope in a patient where the diagnosis actually is the facet joint syndrome, or diagnosis actually is the sacroiliac joint syndrome. So by God's grace, we all pain physicians are good with making the right diagnosis, and not to go only by the MRI finding. Then comes the good clinical skills to ascertain that disc herniation, which is shown on the MRI, is actually causing the patient symptom. So again, I believe that most of the pain physicians are good to differentiate between the clinical findings and the MRI findings. It is very, very important. And for that, it is very important, and this take it as an advice from me also, that you need to read how to read your MRI. You need to read your MRI by yourself. You need to learn how to read MRI. And then comes the good knowledge of spine anatomy as well as the spine fluoroanatomy. And then comes the good experience of spine interventions like transfemoral neuroplasty, intradiscal procedures like nucleoplasty, nucleotomy, ozone injection. Thymopapain is unfortunately not available now. So first you must get yourself proficient in all these basic pain interventions, MIPCs, before you embark upon endoscopy. I won't suggest anybody who hasn't done a good number of intradiscal procedures, discographies, neuroplasties, and to embark upon endoscopy. That is only going to result in a disaster. So prepare yourself well, then you go ahead. So how to start with endoscopy for the practicing? There is a huge number of very competent, actually the teachers and the masters of pain medicine who are already in the field, and understandably well, they don't have the like 1 year, 2 year, 3 years to spend to learn it. So how can they go about? They have got all the experience required, which I have mentioned earlier. So for them, my advice would be that think and believe that I can do it. If anybody else in the pain medicine field can do it, we can also do it. Read and watch extensively. Read all the literature available on the internet. Thanks to Google Baba, we all have got a good number of papers, and thanks to YouTube, we have got good numbers of videos. So read them again and again, watch them again and again, and then comes the one of the single most important point need to be understood by all pain patients. Invest in the best equipment. Invest in the best equipment. This is, I'm again repeating my line, because it is one of the single most important point, that own the best equipment, and there is no other way. Take my word, there is no other way which works. Hiring absolutely doesn't work. If you call someone with the quality endoscopic equipment and giving him some money, and he's coming on a monthly or 2 monthly basis for you to help you, that doesn't work. You do not know the quality of equipment. You do not know the sterility of equipment. And if you want to learn horse riding, you have to own a horse. You want to that is the way to go about it. And only after procurement of instruments, good quality equipment and instruments, start attending the workshop, conferences, and courses. Not before that. There is no point in wasting your money by attending a 5-day or 3-day course on endoscopy if you do not have the equipment, so that you can come back at your home, you get a good patient, and you can start practicing. So unless you first read, watch, procure equipment, and then only you go. This is my humble advice. For all future pain physicians, for those they are already doing DM, PDF, PDCC, PDF, fellowships courses of 1 year, 2 year, or 3 year duration in our India or across the world. For them, and the resident of anesthesiology, for which these courses are largely open till now, join a formal in-house course in pain medicine like DM, PDF, PDCC, fellowship at AIMS and other places, and you would be happy to know that spine endoscopy is part of curriculum at most of these places. So you can be assured that you are covered well enough. When you come out, you get extensive experience. Most of these institutes are very much institute of repute with international repute, and there you are going to get a very good comprehensive experience of all the interventions, including percutaneous spine endoscopy. And these are the few centers. I have made a slide. This is from the last presentation. That they are the few centers for the resident of anesthesiology where they can go and join the formal education in pain medicine, like DM, the pinnacle of all courses across the world. Perhaps the first time in the world, there's a 3 years in-house DM course, and which is now recognized by the Medical Council of India also. You can go and check on the website. Then comes a PDF at SGPJ. This is a 2 years course. Then PDCC, AIMS fellowship, 1.5 years. Slightly wrong here. And then there are another good news that FNB pain medicine has also been notified by NB. So these all are options for my friend from anesthesiology who wants to take pain medicine as their career option. So I am coming back after almost 30 minutes of my talk to the endoscopy per se. So what are the indications? Percutaneous spine endoscopy initially started for the paracentral disc herniations because they were easy to remove. There were less chances of reaching anywhere near to the dura. So they were the initial cases. And we also suggest that you go with the paracentral when you start. Gradually, with the improved understanding of anatomy as well as the better equipment, now practically every herniation or almost all the degenerative condition of the spine can be dealt very well and beautifully with the endoscope. So central herniation, foraminal, extraforaminal, up and down migration, lateral canal stenosis, central canal stenosis, you name it and you can deal it, provided you have the enough expertise as well as the good quality equipment. And there are different equipments required for the different kind of endoscopy. So extensions are indications are increasing continuously. Then comes the approaches. So classic approach, as I told you, by popularized by Dr. Anthony Young and Dr. Gore sir in India, and Dr. Thomas Hoagland in Germany, through the Cummins triangle, was transfemoral approach, and it actually happened after Dr. Thomas Hoagland as well as Dr. Anthony Young discovered and invented the rod lens, a single lens, single channel scope with lens plus irrigation channel plus the working channel. Now it has been divided broadly into transfemoral as well as interlaminar. So some basics of all approaches, be it transfemoral or be it interlaminar, most of these cases are done across the world in the prone positions. Though Dr. Thomas Hoagland and few other endoscopists have popularized and they believe that lateral decubitus position can also be used and is more useful for as a physician as well as for the patient. For anesthesia part, almost everywhere transfemoral approaches, local anesthesia, that is xylocaine or bupivacaine, is used in different concentration for different tissue planes. That is slightly technical thing. You will have good idea in the specific lecture. That initially for the skin infiltration we use 1% xylocaine, or in when we go deeper in the anterior epidural space through the Cummins triangle, we use only 0.5% of bupivacaine because we want to have the differential blockade of sensory motor. For interlaminar, few people use general anesthesia and many use epidural analgesia like the labor analgesia because we pain physician want to keep our patient awake throughout the endoscopy so that he can work as the monitor himself. He can tell us whenever you reach near the nerve or you accidentally touch the nerve or dura, patient will immediately tell you, Dr. Saab, I am having pain down my leg. So types of transfemoral approach. The transfemoral approach can again be divided as inside out. It can be half and half, and it can be outside in or outside out. It can also be divided as posterolateral yes technique that is popularized by Dr. Young and Dr. Gore. Then came the lateral thesis technique, which was by Dr. Thomas Hoagland. Both Dr. Young and Dr. Hoagland were inventing things in slightly different manner at almost same time in 90s. And then came the far or extreme lateral approach, that is by Dr. Sebastian Rutten in Germany. So they have got different indications. So as I already told, we all use the same route. All transfemoral approaches, be it inside out, outside in, or for lateral approach, all of these approaches use Cummins triangle to reach the anterior epidural space and the disc fragment. Then came the interlaminar approach. They are classic interlaminar. They can be stenotic decompression for the central canal herniation, or there can be unilateral bilateral decompression. It's slightly advanced. You will come to know about them as you walk along. All interlaminar approaches are more like traditional midline spinal decompression, but without big incision or directly, and they are directly through the endoscopy. So they are also known as full endoscopy techniques. So just to compare and give you a slight idea and remove the confusion about the different nomenclature, we have made this slide, that comparison of transfemoral approach. So this inside out or yes technique is versus outside in. So inside out is for contained. It can be used for both non-contained and contained, but in my humble opinion, this is more useful for the contained herniation. For a non-contained herniation can also be tried to remove by inside out technique by pulling the tail of fragment and bringing it back to the disc and then take it out. The inside out approach does the indirect decompression of anterior epidural space. This is slightly contentious statement. Few people believe that no, it is also the direct decompression. A few people say no, it is not direct decompression because you stay inside the disc. But the best part of inside out approach is as you are inside the disc, it is much more safer for initial endoscopist in the initial days, because you stay in the disc, you cannot actually harm the any neural structure or dura for that matter, because you'd never come in the direct contact with either the dura or the nerve. If you have placed yourself safely inside the disc. Outside in, it can be used for all kind of herniation, be it contained, non-contained, migrated, down migrated, up migrated, and it as you land directly into the anterior epidural space, you do not go inside the disc. You directly decompress the anterior epidural space and the neural structure in the outside in approach. But there is a price for that there are chances of neurological injury, because you are very near both to the dura as well as for the traversing and exiting in the outside approach. So this is just a pictorial unrest and diagram made by my colleague Dr. Shivani ma'am to help me. Here, this you can see that I think you can all of us can understand. This is the posterior compartment of the spine. This is the axial view, and here you can see the disc which is protruding here, and there are other muscular structure. So when you come from this green line first, this is posterolateral. So this is for the yes approach or inside out posterolateral. So you start some 7 to 8 centimeters or 9 centimeters from the midline, and you go at lesser angle and you reach inside the disc, and there you work at the posterior part of annulus here. Then you slightly decrease the angle and you make it half and half approach, where half of your sleeve is inside the disc and half is looking at the epidural space. And then comes the far lateral approach, where you do not touch the disc directly. You go just in between the dural sac. This is the dural sac and this is the disc, and you go there and work. So you can see it in another picture that inside out, here you can see again the same. This is disc, this is dural sac, this is the lamina and the spine, and this is the facet joint. So your whole sleeve, working sleeve, is inside the disc. So this is a good approach for the initial period when you start your endoscopy, because safety is paramount. Until you get the good orientation of anatomical structures, hand-eye coordination of instrument and tissue, then we would suggest that you go for the inside-out technique. Then comes the half and half. You can see that this is slight modification. Here you do not put your sleeve completely inside the disc, but half of the conical part of the disc working sleeve stays in the annulus or inside the disc, and half is looking at the epidural space. This is the anterior epidural space. Here you can see. So you can have the both of the words. You can go in, you can come slightly out, and you can work directly in the epidural space. And it can be both contained as well as non-contained herniation can be dealt with. So we suggest that after doing 20 to 25 cases of inside out, then you move over to half and half so that you can get better understanding. Then comes the outside in. Here you can, again I am repeating myself, that no entry in the disc. You see the whole sleeve is outside the disc. It is just touching the annulus and directly looking at the anterior epidural space as well as dura. So here you do the removal of herniated material from the epidural space, anterior epidural space, and make your neural structures free. So just to compare the outside approaches, there are two outside approaches. One is Dr. Hoagland's approach, second is Dr. Rutan's approach. So Dr. Hoagland's approach is also known as thesis technique, and Rutan's approach is also known as far lateral technique. So both of them are basically outside in or outside out approach. Dr. Hoagland was a believer of making the root of epidural space bigger, the boundaries of epidural space like Kembin's triangle bigger, by using a sequential reamers, which he used to use under the Siam fluoroscope. So that way it also deals with the foraminal stenosis as well as removing the herniated material. So it is very useful technique still for the degenerative spine and foraminal stenosis cases. And for Rutan's approach, he suggests to use a far lateral skin entry, some 12 to 14 centimeters from midline entry to the Kembin's triangle to the anteroepidural space without reaming the SAP. Dr. Rutan doesn't believe in doing the blind reaming of the SAP, that is superior articular process, which makes another boundary of Kembin's triangle to reach the anteroepidural space. So it is very useful for extraforaminal, foraminal, and migrated fragments. But it is technically demanding. So it should be attempted only after you gain sufficient experience with both inside out, half and half, and Hugland's approach perhaps. So just to compare again and reiterate my point that inside out, completely inside, half and half, half in, half out, and then comes the outside approach. So our suggestion for starting up the endoscopy, that you start with the inside out, then reach up to half and half, then you start outside in by the Hugland's approach, or then you go for the out and out. Then you start foraminotomy, interlaminar. Upper levels, we actually starts and we everybody advocates to start with the L4-5 and L5 level initially, and after you gain good experience, you can go upper level also, L2, 3, 3, 4, L1, 2. People are doing it at cervical level, people are doing it at thoracic level, and then the sky is limit. So it is still getting discovered. This field is something which is getting discovered each and every day. You have another paper, new paper from some Korean friends, from German friends, from Indian friends, and they all are doing wonderful jobs. So there are few basic pre-endoscopic preparations, that thorough HP, history, physical examination, and MRI matching with the findings. This is very important, as I told earlier. Few investigations which we not order commonly are required is one dynamic X-ray, flexion extension, lateral view of spine, where you want to do the endoscopy before doing the endoscopy. To ascertain about the iliac rest. It is a very important landmark, because whenever you are attempting L5S1, it makes hell of a difference. It even changes your approach, whether you want to go transforaminal or you want to go interlaminar. Then in the aged population, it is important to have the residual volume estimation also. For us, pain patient and everybody, it is important. If there is a subtle involvement of bladder, it should be documented before you attempt endoscopy. And you get your patient completely investigated, and there should be a backup. So here you can see that this is one case where you can see this is L4-5 or L5S1, paracentral disc is on left side is there. Here also, this is a reasonable case to start with for your endoscopy. If the disc is L4-5, it is paracentral, and it is not having very long, many years history. Because what happens with the prolonged history of many years, with many attacks of radicular or sciatic pain, disc get collagenated or get calcified even. So if you are hoping that this can be calcified, it's better not to attempt this case in the initial period, because it may be difficult to remove the calcified part of the disc even if you are doing the correct decompression. And how to rule out it before endoscopy? You can order either you can try to see it on the digital X-ray, or you can order better a CT scan to check whether the herniation is soft or. Now we are going to have few pictures. I'm coming to the end of my talk, that we are going to have few pictures to show you how we do it. So this is the PA view. You mark the level, you mark the midline, you mark the level L4-5, L5S1. Then the aim of our placement of needle is that in the AP picture, when we are at the center, we should be in the posterior 1/4 of the disc in the lateral view. So please try to understand that we were doing all the interventions by putting our needle this way that it reaches both center in both AP and lateral view. But here with endoscope, we want to stay in the posterior part of disc. So if this is the disc, this is the anterior part of disc, this is the posterior part of disc. So we want, and this is the anterior epidural space, and this is the posterior epidural space. If I can show you, this is the anterior epidural space. So what we want to do, we want to reach this part of disc, that's the posterior part of disc. So how can we ascertain that we are in the posterior part of disc? By fluoroscope. That when in AP picture, you are in the center of this, you should be in the posterior 1/4 of the disc in the lateral. So here this is some picture to tell you what happens usually when you start, and in the last picture I will go back just with a moment. So here is one very important landmark is this medial pedicular line. This medial pedicular line, we all know it. So it is very important for the safety that once your needle reaches the medial pedicular line in the AP view, you do not advance your needle further ahead. You make a lateral picture and check whether your needle has reached the posterior vertebral line. This is the posterior vertebral line. So you must not go ahead or breach the medial pedicular line until unless you have reached the posterior vertebral line in the lateral picture. It is very important for the safety. Why? I am telling you in the next picture. Here you can see that I have reached in AP picture, we have almost reached the medial pedicular line. But here, what is happening? Our needle is far behind even from the facet. Forget about the posterior vertebral line, which is this. So that means we are going quite superficial, very, very superficial. That means we may land up directly into the canal and puncture the, harm the structures. So it means we need to increase the depth of our needle. Again in the AP view, needle will move only in the AP view, not in the lateral view. Till we reach these two boundaries, medial pedicular line in the AP view, posterior vertebral line in the lateral view. Then you see another picture. Here you can see that in the AP picture, our needle is at around mid pedicular line, not medial pedicular line, which is this. This is mid pedicular line. But in the lateral picture, we have already reached in the posterior 1/4 of the disc. So what is to mean? We are going too deep. If we will go in this same direction, we will land into the deeper part of disc, in the center, perhaps past the center in the disc. And when we will start removing the material, it will from the center rather than from the posterior part of it. So this is again not a good needle placement. So you come back, you do the necessary correction. Remember, always remember, initial needle placement is the single most important of whole success outcome and every complication of the transabdominal endoscopy. So you must not compromise with this. So this is a picture where you need, after needling, after needle you do the discography, then you remove the, you put a guide wire, over that you put the dilator, and then you put the sleeve. So here you can see that it is almost passing out the middle of the medial pedicular line, and here it is in the posterior 1/4 of the disc. Another picture, here you can see dilator has been removed, sleeve is almost at the midline, and you can move your, once you have placed it correctly, then it is your play. You want to work in the disc, you want to work in the epidural space, you want to work in the foramen. So here you can see that I am in the foramen. We want to see the anteroepidural space, I am in the foramen. Here we are in the disc. Another picture, same almost. And this is one of our case, we did it few time back. Here you can see that there is a right paracentral disc herniation, severe pain. Patient did not respond for the transabdominal epidural steroid injection also, and he didn't either want to go for the open conventional surgery. So we did it. You can see the placement almost in the midline in the AP picture, posterior 1/4 in the lateral picture. It was L5S1. So we have to come direct slightly in the angled manner. Here you can see in this is the perfect placement, almost midline, touching the posterior part of this. So then you see the sleeve and dilator in place, and this is a few slides about the endoscopic view where we all initially get lost. So it is very important to remember the side of your patient. Is it left? Is it right? And once you have gone inside, you first orient yourself. Like your patient is lying in the prone, you are on the left side of the patient. Then you see that if you take this like a watch, wall clock, so here it will be 6, here it will be 12, here it will be 9, and here it will be 3 o'clock. So you will ascertain in your mind that on my 3 o'clock is the cranial side of patient. That means their exiting route is coming out. On my 9 o'clock position, patient's caudal side is there. That means there is no root, but there is end plate, or if the downward fragment is down migrated there. On 12 o'clock is the epidural space as well as dura as well as traversing root. And in the ventral or 6 o'clock position is the disc or nuclear material or annulus. So you need to orient yourself first before you attempt anything. And you get this kind of picture initially. Then you clean it with the radio frequency probe. We'll have our next lecture on the equipment and the MRI by Dr. Devendra Singh. He will tell you about it. So then you again clean it, keep on cleaning. Don't get overwhelmed. Then you, after cleaning, you get the annulus and PLL complex. Then you use your annular cutter like equipment to cut the annulus and release the fragment. Then you start, after cutting the annulus, you start decompressing the nuclear material. And finally, you remove it, and you can see this. This is the traversing route here. When it is freely pulsating, you understand that your job is done and patient will be relieved. And this is the final picture. You can see the decompressed area, removed annulus and PLL complex, and this is the traversing route, which is pulsating actually. You will see later on the videos. And the incision is less than 1 centimeter, and this is the disc material. It is bluish. Why? Because of we stained it with the indigo carmine dye, or methylene blue, or indigo cyano green dye. So you stain this dye by the discography. It helps you in initial cases to differentiate between the disc material and completely pain-free. Here you can see that this part post-op MRI, this part is completely empty of the fragment, but the annulus was unfortunately not completely removed, but patient was completely pain-free. So take-home message is that it is a percutaneous spine endoscopy is need of hour and future of pain medicine. So all pain physicians should try and embrace and learn it. And it is a natural progression for us pain physicians. And just to reiterate, it is already a part of curriculum of formal training in pain medicine at most places in India and US. And even in US, ASIP, American Society of Interventional Pain Physicians, have made a code for the pain physicians for spine endoscopy by efforts of Professor Dr. Menchikantai. So, believe one more thing, that you are not alone. So that if you are pain physician, you think that who all are doing. So here are the few number of only few I could put in this slide. There are a lot many more. You can see Dr. Gabriel Jasper, Dr. Palia from Romania. Jasper is in America, Florida. Professor Rastogi, who actually included endoscopy in the PDCC curriculum at BHU for the first time. Sushil Jaiswal at Banaras, our own. Manish Raj, Dr. Sukhdev Datta, US. Professor Gautam Das sir, उनको अगर कोई जानते ही है. Dr. Neeraj Jain, Surange, Dr. Surange, Manish Raj. Where is Manish? He's Dr. Sunil Wagmare. He's in Mumbai. He's interventional radiologist and pain physician. Dr. Kailash Kothari, Dr. Santosh Tripathi. He's a neurologist who is practicing wonderful endoscopy. Our own Dr. Siddharth Datta, who is having a fellowship at his D.Y. Patil Institute, Mumbai, with endoscopy part of curriculum. Karan Jaiswal, Dr. Devendra Singh, who will take another lecture on the endoscopic equipment as well as the MRI. And Dr. Rakhi Gupta. We have got females also, yes. They are not behind to anybody. She is doing wonderful job in Lucknow. So, not many more. So, you are not alone. Don't think. But prepare well, do well, with confidence and with dedication. So, that's all for today. And thank you for your kind patience of hearing. And that's it. Over to you, Doctor.
Thank you, sir. Thank you so much. It was an excellent lecture. It was a very precise and it was very in a very comfortable language. It was, you conveyed all the necessary things what the newer ones, the pain physician, they would have liked to understand. So is Dr. Virendra K. Mohan is there? Hello, sir.
Yeah.
Sir, would you like to say something?
Thank you, Dr. Anurag, for wonderful lectures. And your lecture was quite simple. And it's a very good presentation. You try to cover all the aspects of endoscopy. And I hope the audience understood very well, especially beginners. And it's a beginning for young pain physician. And I think they must understand all the nitty-gritties of the endoscopy. Over to Amitesh.
Any queries, anyone, please put in the Dropbox. Still, the lecture was so nice. I didn't think, and we didn't get any queries right till now. So we are waiting for the queries if anyone has. So the initial part in which the few of the slides which Anurag sir told, if अगर horse riding करनी है तो घोड़ा खरीदना पड़ेगा. That was a very thing. If you want to do an endoscopy, if you want to do to flourish in pain, you have to have, in the last lectures also, what Siddharth told, Dr. Siddharth told, you need to have, as a pain physician, you need to have an RF machine. So if you don't have an RF machine, what else a pain physician will do? Similarly, if you want to do an endoscopy, you need to have an endoscopy set or endoscopy machines or the instruments you need to have. So that was quite understandable. So we are looking for the queries. We will wait for some time, sir. Anything else you want to convey, sir?
So, I think I pretty much told everything which I deemed important. This is the first lecture of our endoscopy series. Second will be on the equipment as well as MRI reading for the pain physicians. And then we will have all these techniques one by one, like inside out, outside in, interlaminar, stenotic decompression, and advanced if the audience wants to. So the aim of Indian Society of Pain Clinicians is to improve the quality of pain education in pain medicine, and the standardization of the education in pain medicine, and to bring the every advancement in the field across the world to our friends to decide for them whether they want to embrace the technique or not. It is up to you. So not everybody is doing, even if you are not doing something, that doesn't mean that you should not know about it. I would like to take an example of the arthroscopy. Not every ortho friend is doing arthroscopy, but they know that this is part of their curriculum, so that they refer their patient for the right arthroscopic orthopedician if the patient requires it. Same way here, if it is not mandatory for any pain physician to be completed to start endoscopy, it is not mandatory. So, but it is a desirable thing. So if you do it well. And there we are here to help you out in each and every way possible. We are here to hand holding. We are here to taking care of you as a society of the pain physicians. So
there is one query, sir, by Dr. Shivani Rastogi. How do you decide between a transforaminal approach or a translaminar approach?
This is a very basic and very pertinent question. Actually, for the transforaminal, there are few limitations, especially at the level of L5S1. There, especially in the men, where they have the high iliac crest, which precludes sometimes the transforaminal route to enter at the right place and doing the adequate decompression by transforaminal route. So their interlaminar is very easy and effective approach. Also, if you want to do the stenotic decompression in the older aged population, whereas there is central stenosis. So that central stenosis is I won't say that it is impossible, because few people believe that it can be done transfemoral also, but large number of people believe that stenotic decompression is better achieved with the interlaminar route. So for L5S1 disc, big disc, interlaminar is good to start with, and for stenotic decompression. And
Okay.
moreover, then it depends on your expertise, your expertise, as well as your equipment availability and all that, personal choice.
There is another query from Dr. Samriddhi. What post-operative advice would you give to the patients in view of mobility, and what antibiotic protocol you follow?
So this is first of all these cases must be done in a dedicated pain medicine OT. Matlab that has to be OT. It is like all, as it goes for all interventions which we do near the spine or anywhere in the body. They need to be done in the completely sterile environment. And first, I will take the antibiotic part. In antibiotic coverage, for what we do, we give prophylactic antibiotic like you give before any other surgery. Same protocol we use, third generation cephalosporin, half an hour before the endoscopy by the IV route. As well as we do another thing, that all these endoscopy, as you will come later on to know, that they are done under the continuous irrigation. So we like to lace our irrigation fluid with third generation cephalosporin also, just to be doubly sure that we are continuously irrigating, and there is no harm, in our opinion, to use the irrigation fluid laced with the antibiotic. Second part, for the post-operative advice, we if for the inside out, that you understand that in inside out technique we make an iatrogenic hole in the annulus, because we take our sleeve as well as dilator inside the disc. So we make another iatrogenic hole in the disc which gets off healed by itself. There is no doubt about it, but it takes time. So for if we have done inside out, we usually ask our patient to use the lumbosacral corset or belt for at least 4 to 6 weeks for any time. We also avoid for the initial 1 week to 2 week to avoid prolonged sitting as well as jerky movement like driving and all that. But they are allowed from the very after 1 or 2 hours of rest, they are allowed to do all their life of daily activities by themselves without any issue.
Very nicely taken, sir. There is another query by Dr. Murli Krishnan. He wants to ask, is there any role of trans-iliac approach to L5S1 test?
Yes, Dr. Murli, there is a role if you are hell-bent upon doing it transfemonally only. So I have done few cases by transiliac route, and it is also good. But the only problem with transiliac route is that you make a hole in the iliac bone, which is not a big deal. It can be done. But as you know, the sleeve is around 8 mm, and you make a hole of 8 mm. So your mobility gets quite restricted. Until unless your fragment is just in front of you, this is not up or.
So, what you were
yes,
saying, so for the question that this whether we want to do for transiliac approach, so this is one of the way if you want to do it only through the transforaminal route. Otherwise, better way to do it through laminar with the window and go in a better way. So that's easier. But, of course, to start with, if you are only familiar with this one approach, transiliac is also one good option.
Okay. Thank you, Siddharth, for helping us in between. I guess Dr. Anurag will be coming in a short while.
Yes, he'll join us. Dr. Sushil is also there, I think. He can also add in.
Yeah, Dr. Sushil is also there. So till now, there is no other questions, queries.
I think we have a suggestion from Dr. Avnish, which is a suggestion that a lecture or panel discussion on complications with real cases. I think
Anurag said there is a suggestion by Avnish, Dr. Avnish, that there should be a lecture or a panel discussion with the complication, the real cases which we normally face. So definitely we are going to have that in a series of this endoscopy lecture series. Anurag sir, can you hear me? I don't think he can hear me. Hello? Dr. Anurag? He needs.
I think he needs to join the audio. Just wait on. He'll figure it out. Just wait on.
Okay. So we are planning to have in a series of after a series of lecture of endoscopy things, then we will have a panel discussion on the complication of the real cases. So that is in the pipeline. So what Dr. Avnish has suggested, that will be in due course. It will be done. Am I audible to everyone?
Yes, you are audible.
Yes. Yes. So meanwhile, for the timing, any queries if you have, you can drop in the chat box. And I hope the presentation was excellent, because it was quite a handy way in which Dr. Anurag has portrayed all whatever he has to say. And for the people who are new in pain medicine, who are willing to join the pain medicine, endoscopy transforaminal endoscopy is a new horizon which we pain physicians are really up to, having an excellent result. Siddharth, would you like to add something on this?
No, I think we are done with most of the part, and I think we can look forward to the future sessions now.
Hello.
Hello.
Sorry for the technical glitch. I had a light drop and net drop. So
it's okay, sir.
So
actually, where we were actually, Avnish Dr. Avnish had a suggestion that we should have a lecture or a panel discussion on the complication of real cases. So he was asking whether we will have a panel discussion. So I told that we will in a series, after a series of lecture, we will have that. So you would like to say that?
That's a wonderful idea, actually. Dr. Avnish. No, I was telling about if Dr. Murli is still here. He was asking for the L5S1. So yes, Dr. Murli, it is absolutely possible for the transiliac approach. But if you can do the interlaminar, that is also okay. So as I told, this is personal choice, but it is doable. So Amitesh?
Okay, sir. I guess everyone is satisfied with the suggestions and the answers or queries. So, would you like to say something? Dr. Viren K. Mohan, sir? Hello?
Okay, sir is perhaps not there.
I think we can end the meeting now.
Yeah.
Okay.
Oh, sir has come.
Yeah.
Let's just
We can wind up.
Okay.
Okay, thank you so much everyone for being here. And then our next meeting will be upon the instrument of the endoscopy, and that will be on the next week's. The timing will be the same on the same platform. So thank you everyone. Be safe, be happy with your family. Thank you so much. Thank you, Anurag sir. Thank you.
Bye. Namaskar.
Thank you,
Keep safe
Anurag.
yourself.
Nice presentation.